Great. Well, thanks to Mark and Charlie, and thanks to all of you for sticking it out to almost the end here. I'm going to talk about SI fusion confusion, and these are my disclosures. So as this audience knows, fusions from the thoracolumbar spine down to the pelvis are increasingly common. At the same time, SI joint pain is increasingly recognized as a source of low back pain. So moving forward, we're going to see more and more patients where we need to plan fusions to the pelvis in patients with prior SI joint fusions, plan SI joint fusions in patients who may one day need fusion to the pelvis, and also plan SI joint fusion in patients who already have fusion to the pelvis. So using some case examples of mine, I will talk about how we might go about doing this. What it comes down to is that, freehand and fluoroscopic techniques are valuable, but some of the enabling technologies that have been discussed in Bill's talk and others, like navigation and robotics, can be very helpful as well. So let's start with this case. This is a 77-year-old woman who came to me with back and leg pain. You can see that she's had a variety of prior procedures, including a 4-5 instrumented fusion, a 3-4 standalone fusion, a left SI joint fusion, and a spinal cord stimulator. She has a mild scoliosis, a pseudoarthrosis, and some proximal segment degeneration. So multiple ways to skin a cat, but for this patient, I elected to do a L1-2, 2-3 lateral. Opened up the back from T10 to pelvis, freehanded the screws from T10 down to the existing instrumentation, and then used navigation to place the sacral and pelvic instrumentation. Vertebroplasties were my PJK prevention of choice, and we removed her stimulator as well. And that's Andrew Chan, who is one of our former fellows. Here, navigation was super helpful because, with the pre-existing SI joint instrumentation, it was nice to identify a spot in line with the thoracolumbar instrumentation, but to thread a nice long corridor, avoiding the previously placed instrumentation. You see, we were able to accomplish that on both sides. And she is a few years after surgery now with some improvement in her symptoms. Different situation here. This is a 39-year-old man with low back pain, history of spinal cord injury after multiple spine surgeries. Actually moved to North Carolina from Arizona, but is not Mark's patient. Presented with back and bowel bladder and sexual dysfunction, paraplegic at baseline. And came to me with these stacked pelvic screws with rod fracture, and you can see a very significantly retropulsed L5 cage. Now, I entered this case with the plan of freehanding pelvic bolt instrumentation to serve as a base for additional satellite rods, essentially converting it to a multiple rod construct. But intraoperatively, actually had significant difficulty freehanding and was not set up for navigation or robotics. In this case, what we can do is, of course, use our fluoroscope and get a nice teardrop view. And they didn't save my pictures from this case, but essentially what I saw was what you see in that teardrop view, which is pretty crowded instrumentation with a narrow corridor at the very top of the teardrop to facilitate placement of pelvic bolts. So using coaxial views and a cannulated gear shift, I was able to thread the needle there, followed with a K-wire, tap, screws, and was able to place additional pelvic fixation with fluoroscopy and additional rod instrumentation. This patient is nearly a year out and doing well. What about patients who need an SI joint and one day might need fusion to the pelvis? So it's well understood that lumbar fusion increases the stress on the SI joints. And one of the risk factors, in fact, for SI joint pain is a history of lumbar fusion. Essentially, it's a manifestation of adjacent segment disease, breaking down of the distal segment. So this is a 40-year-old woman with low back pain with a history of L4 to S1 fusion surgery. And 5 months after fusion surgery, developed pretty classic right SI joint pain, positive maneuvers, response to injections, etc. And here you can see her fusion construct, which looks pretty good, but then the significant SI joint degeneration on her CT. So actually for these patients, I don't plan their SI joint fusions any differently than I would someone without prior lumbar instrumentation. It's possible that, decades down the line, she might need extensions to the pelvis. But using navigation and robotics, you can really plan for tightly packed instrumentation through an incision that's maybe an inch long The middle screw aims at the S1 foramen. You have a screw just above that and a screw just below that. And let's say she should need pelvic extension in the future. You can place your S2AI screw lower with a more lateral trajectory out into the pelvis, or resort to pelvic bolt instrumentation and offset connection. Well, let's skip the video for sake of time, but essentially it shows each robotic screw takes about 2 minutes to place, and so it ends up being a pretty quick procedure when you use enabling technology to help you. And lastly, we'll talk about SI joint fusion in patients who already have fusion to the pelvis. I think proximal junctional issues they receive the brunt of attention in the literature and in meetings like this, but it's important to understand the preponderance of pelvic fixation failure. I was lucky to participate in this ISSG study led by Bobby Slack and Shea Bess, which found that in a group of very experienced deformity surgeons, about 30% of patients develop pelvic fixation failure, whether that's screw loosening, instrumentation fracture, popping off of set screws, etc. While not all these patients eventually need surgery, if they do, it can be pretty extensive. But what if there's a simpler procedure for these patients? This is a 74-year-old man who had prior T10 to pelvis surgery, who came in with very, very focal left-sided pain in the sacroiliac area, responsive to SI joint injections. His imaging does not look good. He's got proximal junctional kyphosis, a sagittal imbalance, and actually loose instrumentation at the bilateral S2AI screws, loose S1 screws, and the presence of air in the discs suggests probably numerous areas of pseudoarthrosis. But in this patient with very focal pain at the left SI joint, I treated him with a left SI joint fusion rather than a proximal thoracic to pelvis, revision surgery in a fairly sick septuagenarian. Quick surgery, home same day, and has had sustained pain relief. Here, robotics again was able to help navigate kind of a crowded pelvis to place 3 implants across the SI joint. We're trying to get this small series published. So far, treated 8 patients in this way. And what you'll see is just low EBL, quick surgery, same-day discharge, and a pretty good improvement in their pain. So I'll close by saying that familiarity with the pelvis is crucial for spine surgeons. Freehand placement of S2AI and pelvic bolts is well described and possible, and when you have trouble, like I did for my second case, fluoroscopy is a useful adjunct. But really enabling technology like navigation and robotics can really help with the ease of these procedures and with helping navigate difficult terrain, specifically when previous instrumentation already exists. And we'll hope to show that SI joint fusion might be a useful salvage procedure for patients who've had spinal deformity surgery and have symptomatic pelvic fixation failure. Thanks so much.